Degenerative disc disease or lumbar spondylosis. Is it an aging process or is it a pathology? My guess is as good as yours. This is a herniated disc with degenerative disc disease. This is also degenerative disc disease. This is yet another degenerative disc disease. However, this gentleman is just 26 years old. He does weight training. He must have started when they were being treated by Raghu and Sardeep for their adolescent back pains, and then became a marathon runner. Has had back pain for 3 years, which is worsening, leg pain for 1 year, which is worsening, quit smoking 6 years back. So yes, these youngsters begin very early. Right now, since he's been with me for about 2 years, he had become a claudicant, paresthesia, neurological weakness in the left L5-S1 with early sphincter urgency, left L5-S1, both involved. This is what the X-rays look like, the AP and the lateral views. This is the flexion extension, no gross instability, nothing to write home about. These are the T2 and T1 weighted images showing you the canal compromise in the sag, but as we've always learned, look at the axial, they give us much more information. L3-4 left-sided, 4-5 left-sided, 5-S1 left-sided. How long has he been having it? Maybe 6 years. He's running marathons, yes, but now he has this urge incontinence sort of an issue with a radicular pain which is not settling down. I've been treating him non-surgically for 2 years. What do I do next? I do a whole spine screening as always, yet I don't know what to do. Yes, he's high demand. Yes, he's a doctor's brother. He's a very, very dear friend's elder sibling. And what do we do? CT scans, electrophysiology, discography, diagnostic blocks, rheumatological workup, do the entire arthritic marker package. We don't know. All this will only give us controversy, not necessarily consensus. Yes, we'll reach a stage where we have to decide between non-surgical and surgical, and that is where that red flag, which was shown by a lot of my previous speakers, comes in. Early bladder involvement, unrelenting symptoms, patient now asking for something to be done, someone you've known for a prolonged period of time. What do we do now? This is where I differ from everybody else. Most of you are thinking of the what's and the how's. I am thinking of the why and the why. I have always thought too much about why the surgery needs to be done, not how and what needs to be done. We spend a lot of time in conferences talking about the what's and how mine is better than yours, or mine is smaller or larger than yours. That's not the reason. The purpose of why supersedes the process of how and the product of what. The why comes from the heart, the process comes from the head, and the what comes from the hands. So the heart is above the head and the hands. Yes, patient needs decompression, fenestration, laminotomy, or interlaminar discectomy. Probably in this gentleman, all three, at 3 different levels. Or maybe a complete laminectomy. Would anybody want a non-fusion option? Yes, for a 26-year-old, I would want it. But do we have them available? We had these rods which didn't work. We had interspinous spacers which had limited indications. We had pedicular-based soft tissues things. We had this diam which came and went. We had a charité disc which came in with a bang and went out quicker. We had a lot of these things which stayed for a short period of time, but nothing really worked. Would you do arthroplasty or interspinous devices? My question was difficult to answer, and I thought, do I need to fuse? And if I need to fuse, will I fuse all the 3 levels? Would I do a hybrid? Would I do a fusion at one level and maybe a non-fusion at the other level with a flexible component? I said probably yes. Intraop, what did I do? Well, I went for the left side. My decomp was most important, so I decomped everything. Micro decompons at the highest level, a soft decomp with stabilization with some flexible rod in between, and a solid interbody at the junction lumbosacral. This is immediate post-op. You can see the staples there. This is 7 years post-op. God was kind. The gentleman continues to run marathons. On the sly has restarted smoking, but we are still very, very lucky. Treat not the man, but the scan. Minimal invasiveness, risks, and cost having lasting effect is the principle of miracle. Treat not the man. As I've said, for a microlumbar decompression, you may just take 20 minutes to perform the surgery, but you must spend 2 hours with the patient and the caregivers to explain the entire process. I believe this is the most important part. 80% of us suffer with low back pain. Less than 45 years of age is the largest cause of absenteeism from work. And when we look at lumbar disc herniation, we've gone through Kirkcaldy-Willis's various stages of instability to restabilization and autostabilization. We go through it all the way from up to down with disc degeneration going there. But truthfully, it is universal. Each one of us will have lumbar spondylosis. But do we always have a disc herniation? Not. Why does it happen? Well, there's a tear in the annulus, and what does it cause? It causes nerve pressure because something pops out there. The nucleus pulposus with a part of the annulus goes and hits or irritates the nerve, causing a radiculitis, mechanical plus chemical. Let's look at this 45-year-old gentleman, 4 days history, severe right more than left leg pain. Neurologically, right L5 grade 4/5 MRC. How many of us would offer surgery to this patient? Just a show of hands, please. Yes, there is a significant number of people who have offered surgery, and they are probably right. However, I stand here pleading my case why we should not operate this patient immediately. And why do I say that? Because for 33 years I practiced something, and now we've got adequate literature to support it. Please understand, almost 50% of the people will resolve very, very soon, 49%. 39 to 40% will resolve sooner, better than later. And just 12% will remain unresolved beyond a particular period of time. Hence, do not be in a hurry. Why does this happen? Because there's a macrophage infiltration and neovascularization. Both the physical as well as the chemical part will be taken care of. And that's the way forward. Do these discs resolve? It's such a large disc, itna bada hai, kaise jayega? It will go. If there's more degeneration, if there's a greater size of a herniated fragment, they resolve better and quicker. In fact, it's the young disc which does not regress as compared to those elderly extrusions. There's no correlation between the site of the herniation and the regression. They all will regress if you wait long enough. Surgery happens when one of the two get impatient, the patient or the doctor. Please also remember, there will be improvement in clinical findings much before there's an improvement in the MRI. 60% of people will be better at the end of 1 year of without surgery, 90% in the surgical group. So please understand, you have just a 30% chance, but that's at the end of 1 year if you've been impatient. If you're patient enough at 10 years, there's no difference between surgical and conservative care. Let's look at what happens. There was a double-blinded study using NSAIDs. There's no difference between use of NSAID and placebo as far as long-term use. Short-term, yes, 2 days, 5 days, fair. But don't indulge in long-term use. Epidurals. Well, there's no difference as far as degree of regression. As a pain reliever, hiding the effect, yes, but treating the cause, no. Do they have any influence as far as natural history? No significant difference in more than one study between use of epidural steroid and not use of any. That's to show you over 10 years. Yes, in 1 month, surgical patient is much better than non-surgical. At 1 year, they're getting closer. At 4 years, very, very close. And at the end of 10 years, there's hardly any difference between the two. Yes, what is the natural history? Overall, it's good. Recovery will happen within 3 to 6 weeks of the onset in majority of patients. Sensory fibers, most susceptible compression, are the last to recover. Resolution may not get affected by surgery. So please understand that you don't always succeed with surgery. In my hands and in every hand, there's a 7 to 10% recurrence rate, if not failure. What are the good outcome signs? If there's no cross SLR, if spinal motion in extension is relieving pains, if there's a large extrusion, if there's relief of more than 50% of the symptoms in the first 6 weeks, If the patient is in a good fitness level, if progressive improvement in neurology happens in the first 12 weeks, and a motivated patient, motivated, no psychological monkey on the back, and self-employed, these guys do well. Who are the ones who don't do well? A positive cross SLR. Pain even in extension. A contained subligamentous disc. No recovery at the end of more than 50% even after 6 weeks of any form of therapy. Progressive deficit cauda equina. Psychological issues, workmen, 20-degree, 30-degree do not affect. Response to bed rest does not affect. Response to passive care, no. Age, gender, no. Degree of neurological deficit except a cauda equina. The rest don't matter. EHL 4 plus is not an indication for surgery. What's the role of bed rest? Ladies and gentlemen, there is no role of bed rest except for the first 2 days of bed rest. They're as good as 5 days, and more than 7 days actually does more harm than good. That's a Cochrane review coming next. What else do we see? Well, the author's conclusions are that there is no role for traction in low back pain. Okay, either alone or in combination with any other treatment, no impact on pain intensity, functional status, and Globus return of work. So there is no role for traction whatsoever. What's new? Well, chemonucleolysis is just thrown out when chymopapine called hesitation is coming back. There are newer drugs called MMP7 coming in. Ethanol gel is also working similar to chemonucleolysis. Artemin is a new drug which was actually touted to be as good or better than TNF-alpha antagonist, which came and went. Tenizumab, similar to the ones that we use, the monoclonal antibody that we're using for osteoporosis. PRP has a remarkable new role. Stem cell plus minus, not very sure, but back school, modification of lifestyle has a major, major role. And thinking process of the patient and the doctor. Please be patient enough. These patients will settle without a surgery. So in summary, most disc herniations resolve spontaneously. Large migrated fragments resolve better than smaller protrusions. I repeat that. Majority of patients with spontaneous improvement will improve within 1 to 3 months. Only operate in cauda equina, profound deficit or a foot drop, unrelenting pain, which is patient specific. Ladies and gentlemen, tread cautiously into spine surgery, for things are changing as we talk. What is state of the art today is history tomorrow, obsolete the day after. Please do what works best in your hands rather than be market driven or techno savvy. It's time we get out of this rat race. Don't listen to everything, but listen to what comes out of your heart. Decide on the purpose of surgery. The process and the product comes later. If you go and only do the product, that's immediate post-op, and that's soon later. So please be careful. We are living in a country today where behind every successful person, a surgeon here, there are a lot of unsuccessful years. I have had 33 of them. And I believe good results come from experience, but experience only comes from bad results. Thank you all for a very patient hearing.